further ado, what you got for us, Eric?
Well, so we talked about this a lot last week. Sacral torsions to me it's basically the sacrum, it's the sacrum's way of performing functional movements. So these are things like striding, these are things like axial body rotation, things like that. This is how the sacrum moves in real life, right? So the idea with striding is the first thing that you have to think about is which sacroiliac joint is loaded. The loaded sacroiliac joint is going to be the more mobile one. We were talking about the fibrocartilaginous pad in there, that intra-articular ligament, however you want to describe it, being kind of a compressed structure at that point, and that allows for more movement in between the two surfaces. So thinking about that side of the pelvis, that sacroiliac joint, if I'm standing on my left foot in mid stance with my right leg swinging through, that left SI joint is what I'm naming my torsion off of. So any sacral torsion that's occurring at the pelvis at that point is occurring on the left axis. Now the naming of a sacral torsion is done based on the direction that the front of the sacrum is facing. So if my sacrum is looking like this and I get it to turn like that, now my sacrum is facing toward my right side, correct? So it is a right on left axis torsion, right on left. We'd consider that a posterior torsion. We name it based off of where the sacral base deviates to. So a posterior torsion would be that, I guess you'd call it a contralateral torsion, where you have the right on left. An anterior torsion would be more your right on right.
And striding on this one, what you're talking about is the weight-bearing leg, and say the left leg is weight-bearing. So we know that that's going to be our axis for labeling. And with that, if I'm standing on my left leg, if I have a posterior torsion to the right, basically that's labeling what's going on the right sacral base, not the left sacral base.
Yes.
Correct. Because basically with this model, would you say the left sacral base is then fixed as the axis point?
It'd be more of a pivot point more than anything else. Because what we tend to look at when these scenarios is essentially the gait motion is being driven by the psoas and the contralateral pelvic wall. So that'd be the piriformis, that'd be the short component, etc. And so the idea of these sort of movements that occur like this on either side, that's what's driving that. So if you think about what's happening above the sacrum, when you get into things like terminal stance, so say on the left side as your right leg is swinging forward going toward heel strike, that left side is moving into hip extension and anterior innominate rotation or innominate extension. You're creating what they consider a reversed origin insertion tension on the psoas, where now the origin is essentially going to be the lesser tuber or lesser trochanter, right? And the moving component is now going to be the spine, where we're going to get that ipsilateral side bending, contralateral rotation. So that's exactly what's happening at the sacrum, right? So as we're getting this side bending above it, we're getting this rotation, and it's taking the sacrum with it, right? So the left sacral base has moved more forward, the right sacral base has moved more posteriorly. The difference is because it's essentially set to mirror the lumbar spine, you have that bit of a contradictory movement there, where the sacral base is essentially the pivot, because the movement's happening above that, and then the movement's happening below that. So yeah, if you want to think about the sacral base on the left at that point being the fixed point, it technically is, but the movement is occurring across that left axis, which means the left side is actually the more mobile side. It's just the vast majority of it is the more mobile, and it's that sacral base, that point up there where it's more fixed and pivoting around. That gets to sound a little bit difficult without me being able to kind of show you what it looks like in real life.
Yeah, that ties in nicely to what we talked about earlier about that it's a pivot point, not so much a motion point. So it kind of ties in that nutated position that even Diane Lee would talk about.
Yeah,
So that left
absolutely.
sacral base needs to be held in that nutated position to act as that pivot point.
Yeah.
If we have that pivot point moving around, now we have an altered center of axis going on and an aberrant motion per se on that left on left. We'll always kind of stick with the left leg there as it goes. So does that make sense, Katie? How that nutated sacrum on that left side, we're talking about the left leg in weight bearing. Okay, the axis is going to be, you know, basically on the left side or left axis, and the sacrum is held in nutation.
Yeah.
We do some of the testing that we looked at earlier, and we get and now all of a sudden we get a shifting pivot point, i.e. the sacrum counter nutates during the left loading. We lose that axis of motion that Eric is talking about. And that's an aberrant motion that I mentioned earlier. Does that make sense?
Right. Like yes. Because it's going to be the most fixed point as long as you stay nutated.
Yes.
But if you lose that, it's
you may lose
not going to be a stable.
that left axis of motion. Is that consistent with your thought, Eric? Oh, Eric's
Either
frozen.
he's deep in thought or frozen.
Yeah. I've seen him stay still for 4 or 5 seconds, but never this long. So
Yeah. You start thinking about how does that occur.
you're breaking up a little, Eric. Nope. And now he's gone. He should be back in just a moment. So it kind of, that's consistent with what we had talked about, but now talking about what we spoke about a little bit earlier as far as what's going on with the hip and psoas. So, you know, we talk about how the psoas is going to counter that motion. Psoas should be firing at the last part of, you know, basically once you go to heel off to toe off, psoas starts firing and initiating, pre-toning that. So that would be the mechanism by which he's talking about that psoas firing and being able to basically pull the sacrum and create that, you know, distant or reversal of origin insertion point in the spine. Let me unmute Eric and see if he's back. Hey, Eric, you back? So then if we talk about psoas activation, as soon as Eric starts moving again, we'll give him the floor. So as soon as the psoas basically pulling, so now if I'm in a flexed position I talked about, a position which doesn't tension psoas, it's going to change the system a little bit. And again, it's always, do I have to absolutely correct it, or is this person an appropriate mechanism left of center? I.e. that, okay, now if I'm slightly leaned forward, my psoas isn't going to build up that tension, which may reverse the origin insertion components. It changes the gait, but how is that then reflected in my pain pattern is what I'm going to look for in gait. Does that make sense, Chris?
Yeah, what do you think that, or what do you theorize people use to get power or to gain efficiency if they are in that forward lean? Like what type of compensations are we looking for?
Well, think about it. And if I want to teach somebody to run faster and decrease stress on the hip, the one thing I use is increasing their anterior center of gravity with a forward lean, a forward body lean. And as soon as I get that forward body lean, I'm going to decrease the extension moment and stress at the hip joint with a forward flexed position. So if my body is more erect, I'm going to have to use more hip extension in my drive off, because now my hip can drive off from the neutral position extended. If my body lean is here, I've now extended my hip's ability to extend without increasing the tension or the moment at my anterior hip capsule or through my psoas. And that thing by intentioning it out. So if I don't relieve anterior hip stress, it's one of the first key things I do is get them lean forward. Now there's an energy cost to that. They're going to run faster. They're going to probably land more midfoot. So in some ways you have to be a little more fit to be able to make that adjustment in the hip. But what goes along the hip is kind of moving down SI joint, you know, lumbar spine, hip, all of which are in there. So what you see a lot of people do is they'll do this, okay, lean forward, they do this, they tilt at the pelvis. So now all of a sudden they're not even finishing probably in hip neutral, they can probably finish in hip flexion. So you have no stored energy in psoas or hip capsule. You know, they have to kind of drive the hip forward a little bit more. So it's usually a little bit more of a lazy gait. You don't have that kinetic energy stored either in hip capsule, psoas, rectus femoris, coming through the back end of the stride. So it tends to be the more shuffle gait you see. They lean forward, they tend to kind of shuffle. dropping one foot in front of the other, and you see there's just no stored kinetic energy in this individual. You know, there's no hip drive, where, you know, desired hip drive would be around 45 degrees. This person's probably dropping in at about 20. So your older running style. And that's what I see as that person. Again, it's not the end of the world. Older people do it for a myriad of reasons and their inability to store energy, as you look at the runner who's over 50. So it's not always bad, but I just know, okay, what's going on at the hip? Are they storing energy and releasing it? Or is this, they using another strategy of forward falling? And do they need to have a more active hip flexor to drive it? Because, you know, depending on that forward lean, you may actually require less hip drive. That makes sense, or is that just confusing?
Made sense to me.
Okay.
It's just about where do they get the power from? You know, I mean, where are they driving things from? Are they having to use more muscle recruitment? You know, sometimes that leads to overuse injuries in patients those ages. You know, we see it a ton in patients in their ankles, where they develop an Achilles tendinopathy that they, half the time they don't even know that they have. But as you're examining, I mean, you could be looking at them for lower back pain, you could be looking at them for foot pain, you could be looking at them for knee pain, and you're suspicious that the ankle is stiff and it's, you know, affecting their stride power. And you check out the Achilles, you know, kind of just dig in on the front, the anterior side of that Achilles, and it's just ridiculously tender. Most of the time is they're not getting enough of that terminal stance position into dorsiflexion of the ankle in order to stretch that tissue and recruit that kind of rubber band effect, where when they lift the heel, it recoils and helps drive them forward. So what they're doing at that point is they're pushing actively with their calf muscle to try and get their power back, to catch up with the other side of the body. So it's the exact same thing can happen through the pelvis. You know, if they start losing that ability to create some of that passive energy construction, whether that's due to a TL junction lesion that's affecting the torsion coming from above, whether that's a sacral torsion issue, or even if it's just a rotational issue through the pelvis, you know, or some sort of lack of hip extension, you're not getting as much of that passive tension on those inert structures, joint capsules, ligaments, and even some of the more static tendons and whatnot. You gotta replace that energy somehow, otherwise you're just gonna end up spinning in circles, right? So you gotta bring that back in, and a lot of times that's where you see somebody driving harder with the psoas in order to catch themselves up. You know, they may end up with, you know, a anterior subluxed hip, or they may end up with a, you know, psoas hip flexor tendinopathy, something of that nature. So yeah, it's just a question mark of where they're, you know, where is the chink in the chain here? You know, Dave's described it as failed load transfer. It's like, but that's true. You know, I mean, you could describe it differently. Maybe it's, you know, failed load initiation, I guess you would call it. So but however you want to view that, it's still a dysfunctional component to the activity, and they have to make up for it somehow.
That's a great point. Commonly what you see is when somebody can't store energy in the Achilles, that it creates increased hip drive. So prior history of Achilles tendinopathy, you know, there's no stored energy. It could be lengthened to a point where it can't transfer load effectively, so they go to a hip drive strategy, or they could just keep beating down on the Achilles in a lengthened position, and they develop the Achilles tendinopathy from the overstretching. They often aren't the super tight ones. Many times you see this tendon is actually over lengthened. It can't store energy properly.
You think sometimes it kind of it works into that extension rotation syndrome, like Sarman identified with, you know, excessive rotation extension through the lumbar spine to try and develop that power?
Yeah.
Yeah.
Yeah. Because essentially, I mean, if you're thinking about it, you know, where's the next biggest, you know, set of muscles that you're going to be able to get? You're probably going to be able to get the obliques to kick in, something of that nature, right? And so because you can't produce the rotational components, you're not distributing that load up through the thorax. You're going to distribute the load somewhere. So the neural arch of the lumbar spine is going to be where that ends up happening. You know, it's a very easy way to break down the lumbar spine. You see it all the time.
Instead of a subluxation, could you also have that compensation of getting an excessive range of motion, like the runner that you were talking about that you saw this morning, Dave?
Yes.
That excessive hip extension coming because of that part of the lower leg not being able to build up, because that's what we talked about in the peripheral course, Eric, was that spring loading mechanism of the foot, and then that leads to that excessive stress on that lateral meniscus, so often that subtalar joint going up the chain, and then if he's just compensating at the hip to avoid fixing that down the chain.
Sure. Yeah. I mean, again, you can relate these things to any different part of the body, however you want to do it. I mean, you can relate it to throwers, right? So, you know, oh, I'm lacking upper thoracic extension. So where am I most likely to make that up? Like, oh, well, I'm probably going to hypermobilize external rotation of my shoulder. I may tear up my labrum. I may produce that peel back mechanism of the biceps. If it doesn't go there, it's probably going to occur at the medial elbows. They're going to start creating some excessive torque there. You know, you just have to start thinking about the example we used in the peripheral course of that lateral meniscus. Lateral meniscus is completely flattened out by mid-stance during striding, right? So you have to think about, well, where else in the body, in the lower chain, is at its full end range closed pack position at mid-stance? And the only other component that's there by that point is the subtalar joint. So when you start thinking about, well, if I'm lacking that movement at the subtalar joint, where is the most likely place to break down? Well, it's going to be the other thing that's already at its end range, right? And so that would make that meniscus the most vulnerable. So similarly to, you know, the situation Dave was talking about, I didn't hear what it was, but, you know, so they're using excessive, was it hip extension to make up for a lack of ankle dorsiflexion?
Yeah, dorsiflexion. He was basically, his hip was translated anteriorly, internally rotated. So he had excessive internal rotation of the hip.
Yeah.
And then compensation down lower with a laterally rotated lower leg. So any any movement he did created rotation throughout the entire system. He was excessively mobile versus tight.
Yeah, but this person is going to have a hard time generating that energy anyway, because they're already toward that stretched out range, right? So when you're trying to create kinetic energy, you start from a starting point of neutral, and then you increase tension. But if they're already here, there's not that much increase of tension that they're able to generate. Does that make sense? So if this is 100%, and they're instead of starting here, they're starting at 40% of that stretch already, there's not that much more that they can generate because they're never going back toward neutral.
And that's
so
that
yeah,
increased neutral zone that we talked about.
Yep.
Absolutely.
Exactly.
Absolutely. Yep. So you end up with some inhibitory processes there of the muscles around that unit, you know, how that's being worked. So, you know, being able to restore that neutral zone is a good idea. You know, sometimes it's not a possibility because there may be some architectural breakdown at that point. You know, some of these true, you know, you consider linear instabilities, happens to a lot of people. So when that's the case, it's just like, well, how well do you control it? You know, and then you're into motor control stuff, more of that neuromuscular re-education component, and how do you train them to control that neutral zone better? You know, I like Dave's idea of, you know, just, you know, get some runners to lean forward a little bit. It brings gravity into the equation. It brings momentum into the equation. So you're adding some of the forces back into it just by using what's already there on them in nature, right? So it kind of depends on what their task is. You know, we talk a lot about runners on these calls because, you know, we're kind of in the lower quadrant, lower half phase right now, but you can apply it to the upper extremity as well. You know, if you have somebody that has a labral issue or an instability here in the shoulder, you know, how well do you get them to kind of control that neutral zone? You know, what's the method for that? Well, you got to improve recruitment and dynamic stability of the rotator cuff. You know, so being able to kind of get them stable in different positions of the throwing complex, you know, that sometimes that's a tough thing to do, but it takes time. But it's the best way you have left with what you're dealing with without having some sort of external stability done.
Yeah, and even the guys I saw today, you can look at. I didn't get into it today because I didn't look at him run yet. But what you're probably going to end up seeing is that if his neutral zone is expanded, you know, what is his firing patterns, his psoas, and even in that sense, gastrocnemius soleus can be altered. Because how's he generating that forward drive? If he's not storing any energy through psoas and hip joint because basically his range is excessive, so they don't have stored energy. So he may need either, again, more, you know, a little more vigorous psoas, you know, drive, or it could just be a lazy stride where he just kind of flows over the top of that foot with very little forward momentum by the time he gets the toe off because he's not consciously driving the leg forward. he needs to amp up his neural system so that he's efficient and toned. So he could do it through a very lax running style of where you kind of throw one leg out in front of the other and just let that other leg follow through. Or is it more of an active running style where he has the system engaged, he's maintaining tone, throughout the entire system. My guess is that he may be a little bit on the loose side when I watch him run. Maybe I'll watch him run before next week, and I can get a good sense of it. He's a good guy. I can maybe get him filmed. So it's that idea that you get the sense of what is normal. Where's my mental starting point with somebody, and then I'm not afraid to go left or right on it. Like, here's where their gait should be. Here's where the joint is. I now have an expanded neutral zone, excessive motion. He could be basically facilitated where he gets into a movement. Now, okay, everything fires on him hard to stabilize the system, and he's probably good, or he could be very lax. So it's just kind of knowing, like with these, even the sacral torsions, getting a sense of what is baseline. And from baseline, I can then move left or right, depending there. And if it doesn't match a clear pattern that I'm expecting, so what? Let me figure out the pattern I have. So I don't beat myself up trying to make it fit in something where it's not fitting.
Yeah. And sometimes that's an awareness of the way it was described to me when I was doing some of my courses, this body type versus environment component. If you think of somebody, taking the example of somebody of an axial rotation, somebody that needs to produce a lot of axial rotation, the one that I always think of is the cashier at a grocery store that's standing in the same spot, their feet are fixed, and they're taking things from here and they're running them across a scanner and moving them to the other side, right? And they're standing on a hard surface, concrete surface, something like that. Not a lot of give, so there's a ton of ground reaction force forcing its way back up through the system there. If that person has a very stiff body type where they need essentially a lot of movement through the feet, through the tib-fib joints, through the SI joints, and through the TL junction area, but they're real stiff. That's just the way they're put together. They're kind of more flat back. They don't get a lot of hip extension. They don't have real mobile feet. They're going to really struggle at that job, and they're going to break down eventually. Similarly with ballerinas. I worked with a ton of ballerinas back during my time in Colorado Springs, and they are the most Darwinistic, I should call them the most anti-Darwinistic athletes of all time, because they require extreme flexibility in almost their entire body except for their feet. Their feet have to be rigid because they go up on such a high point, and the foot has to be able to lock up very effectively. That doesn't fit a profile. You're either here's the middle, you're stiff or you're flexible. You can't have body regions going in separate directions based on selective decision of where you need them to go. That's not how evolution and nurture work. The body is what it is. It should be relatively stiff all over if that's their body type, or it should be relatively flexible, or somewhere in the middle. But it should match up with each other. So if you see somebody that comes in and you're looking at them and you're like, boy, this person's pretty mobile, and you're taking them through an exam and you have them turn to the left and they get about 30% of the range you'd expect, but everything else is just free, and they've got all kinds of movement through the shoulders and their hips are real mobile. Odds are pretty good the outlier there, the loss of mobility in the one motion in seated rotation, is probably the dysfunctional component. If you have somebody that comes in and you're going through them and you start getting, and you think, well, this person's really stiff, they barely get their arm overhead, they can barely turn their head more than 60%. The knees don't even get to full extension, stuff like that, and you start hearing clicking and clunking in joints, things like that. It looks like it's pretty mobile in certain directions. Odds are that's the outlier, right? That's the one that's dysfunctional and it's hypermobile or it's unstable. So sometimes we get so narrowed in on what we're looking at that we don't see the whole picture there. So it's always good to kind of step back and just get a view of what a person really, what kind of body type you expect them to have. And, again, having some idea of what their task is. If somebody says my feet kill me after I'm done at work, so, well, what do you do for work? Well, I work as a cashier. Okay. So, you look at them and you're just like, boy, you're really stiff all over. This is going to be tough for you to deal with. But it may be something as simple as just having them put down a pad, some sort of foam cushion pad underneath their feet when they stand at their register. That may be enough to help them absorb those torsional forces. So it's not even anything necessarily that you need to go in and do. It's just an ergonomic adaptation that they have to make. Does that make sense? Yeah, okay, good.
Right. So as you talked about this in the past, Eric, when you see sacral torsion lesions in the gait cycle, and where are you mostly seeing them? What is the most typical sacral torsion lesion you think you encounter?
The most common one that I tend to see is it'd be the posterior torsion. So it'd be a right on left or a left on right.
Mm-hmm.
And in general, the most likely issue with that is that you're going to have a hard time creating posterior innominate rotation at that point, right? Because if we're looking at, right side innominate, we have that right on left where the sacral base is turned, the sacral face is facing right, that sacral base is moved posteriorly. It's essentially limiting that posterior rotation of the innominate there. That's the one that I see the most often. There's a lot of different ways that you can develop that sort of problem. There's some suspicion that it comes as a result of some sort of old disc lesion. A disc lesion essentially on an ipsilateral side will tend to inhibit psoas recruitment. And that's where we tend to get that antalgic gait where the trunk will kind of lean away. It has to inhibit the psoas in order to do that. So that allows that sacral base to drift posteriorly. You could also get it as a compensatory problem where we need to develop more stride power on the left side. So you're getting more recruitment out of the small portion of the glute max, the short portion of the glute max, and the piriformis. And so it's actually pulling the sacral ILA anteriorly. You'll get that occasionally. Same thing with a pelvic floor issue on one side versus the other will tend to tilt that ILA, and that'll inhibit some of that psoas tone. But you could get it as far down as the foot and the ankle, as far as how are we driving these things. Anything that's going to force an anterior rotation of the innominate would do it. So anteriorly subluxed hip's going to limit hip extension. That could do it. Beginnings of osteoarthritis in the hip, that'll do it. Ankle dorsiflexion problems, subtalar joint eversion problems, anything that's going to, kind of artificially lengthen the functional length of the limb. So limiting that terminal stance position will tend to do that because it'll just force that thing forward. And then you have to adapt to that by creating more of that torsional force through the sacrum. So again, it tends to mean that those sacral torsion things are more of this compensatory mechanism. I see it a lot as being a compensatory problem from the lumbar spine because there's some sort of facilitation of the psoas or some sort of inhibition of the multifidi. You see that, and that allows these deviations from time to time. But they're less likely to occur as a pure acute trauma.
Yeah, it doesn't exist on its own per se.
Yeah, I would think maybe it's a possibility in somebody that's real flexible, maybe even bordering on unstable in the sacroiliac region. You may have to think about somebody that's like a pregnant female that's out playing golf. Pregnant
female, somebody playing a rotational sport with some maybe microtrauma or predisposition.
And certainly with somebody that has some breakdown of the fibrocartilaginous pad, so somebody with an active inflammatory condition, an ankylosing or a rheumatoid arthritis or something of that nature, something that chews up that cartilage and destabilizes that joint. You can get that with the type of population as well, with these sort of high velocity rotational things. But the more likely scenario is it's being held in an abnormal position for prolonged periods. And you're getting kind of what I call the silly putty effect. That fibrocartilaginous pad is so strong and so powerful, you hit it with a hammer and it just bounces right back at you when it's healthy. But you put this slow, sustained load on it where you start kind of changing this position gradually over time. Eventually the shape of that, just like silly putty, when you lean on it, is going to change shape as well. And then it's just the new normal. That's just the way the joint's put together at that point. You have to really work hard in order to kind of try and correct that. That's why these sacral torsions can be kind of a stubborn thing to get rid of, because you have to really focus on trying to maintain a neutral position or a nutated position. It depends on which direction it's going in, but you have to really focus on getting them to maintain that for you. And again, this kind of goes back to the stuff we were talking about, the telehealth stuff. If you can show them ways to do muscle energy techniques to correct these things on their own, which are easy enough to do because it's just positioning themselves and resisting one muscle. If you can do that, then you hold a better chance, because they can do those things multiple times a day and help to recorrect those things. Whereas coming in and seeing me twice a week, odds are that's never going to stick on its own unless we do it twice a week for a year or more, depending on how substantial the alteration is there. But yeah, so I mean, from my perspective, there always going to be some sort of chronic thing, barring some sort of something in the history or the subjective that suggests that it could happen otherwise.
How many of these do you feel when you feel this sacral torsion? You go and do the mobility testing on, what percentage do you think are stuck that you see versus they're in a counter torsion position and you go to test it now? You think you have let's say you find it in standing, and then, okay, you go and move them. You look at them lying on the bed, and now, okay, you can move this joint around. What do you normally see as far as the mobility of that? How many are actually stuck versus unable to motor control?
I'd say it's probably pretty close to 50-50. The problem with it is sometimes on that first visit, when you're investigating that SI region for the first time, you may not even know that it's a sacral torsion. So if they come in, and like I've been telling you guys, my usual thing is when I'm suspicious that the SI joint is either the pain producer, so I'm looking at it as the area I need to treat to relieve pain, or if I think it's a functional deficit that I need to correct in order to improve something above or below. I'm usually looking at doing some sort of screening test for the lumbar spine, some sort of screening test for the TL junction, and then some sort of screening tests for the lower extremity joints. Basically, I go off of the supposition that most sacral torsions are going to be driven by lumbar spine pathologies, and that the innominate rotations, the more kind of direct singular planar lesions there at the SI joint, are going to be more driven by TL junction issues or problems in the limb. So if I'm suspicious that I have a sacral torsion based off of what I come up with on my screening test there, that I'm seeing this is more of a lumbar problem, then it basically just becomes how do I treat this thing? I'm looking at end feel at that point. When I go in and I do my passive mobility tests on the SI joint, I say, is it jammed? Does it feel neuromuscular? Does it feel more soft tissue? Depending on what I feel, that's how I pick my treatment. I would say 50% of the time it is jammed. These are the people that have had a more chronic problem, and 50% of the time it's extra articular. It'd be something like a soft tissue lesion or something like a neuromuscular imbalance, something of that nature. So split up that extra articular stuff however you want. I see far less of the capsular stuff because that would suggest an active inflammatory process there. And those are usually pretty easy to pick out because the patient usually describes this, a true sacroiliitis sort of illness script to you. And if they don't, maybe they had it previously and it's calmed down by then. But odds are they're just looking at it like, no, it hurts when I stand up in the morning. It hurts a little bit when I roll over in bed. It's not as intense as the true sacroiliitis is. But I think it's I would say it's pretty close to that half and half that are fixated and that are not. It doesn't really help that much because.
Could you repeat what you said about if it was more planar, you're seeing ilial planar issues, you look more lumbar spine. If it's more of a sacral torsion, you look TL junction. Did I catch that correctly, or could you?
No, you got it backwards. So in general, the two things that are going to create more of these planar movements, the pure innominate rotations around the sacrum, are going to be things that come from further above. So the TL junction, because that's going to be more of those paraspinals coming down and attaching to the innominate and then pulling the innominate into a rotational position. So it's more of this linear motion. The other thing would be coming from below, where you have the force of limited stride length kind of coming up and pushing into that and forcing that into more of a rotational position. The sacral torsion I tend to see more often, way more often, like 95% of the time with a lumbar spine pathology, because it's going to create more of that oblique neuromuscular dysfunction, problems with recruitment of the psoas, whether it's hypertonic or hypotonic, which is very rare, but it's just inhibited. Similarly with the multifidi, again, it's more of an angular muscle when you're getting around the sacrum and the lower lumbar spine. You can have it a bit with dysfunction of the pelvic wall, so the piriformis and short glute max, but having isolated problems there are pretty rare that don't also have some sort of component that's affecting the lumbosacral junction. The one example there that may come to mind is actually a traumatic fall where they fall and land on the backside of their hip, and you get some sort of hematoma in the muscle, and it scars down, and that's just not going to allow the lengthening that you need to produce that anterior sacral torsion, because just that lower half here, that muscle here, isn't going to lengthen to allow that sort of thing. So you could see that maybe, but they'd have the definitive mechanism of how it started, where they fell right on their butt. Otherwise, when they come in with these, I don't know how this happened. It came out of nowhere. It was gradual onset and developed into this. At that point, I'm more suspicious if I'm suspecting a sacral torsion that's going to be a lumbar spine issue than it is going to be something in the hip, limb, or TL junction. The one caveat sometimes with the TL junction is T12. If you have an isolated T12 problem, it can cause a very similar problem to a lumbar spine issue, because it operates, the bottom half of T12 operates like a lumbar segment. So getting something like that, it can be a bit deceiving, but you should still pick it up during your screening test. Is that good, Chris?
Katie, any questions?
Yeah, that is definitely. I remember you actually talking about that in our course. Now that you when you repeated that, so I thank you for covering that. I appreciate that.
No problem. No problem. Katie, did you have something? Head gonna explode? You're muted.
Maybe right now, but I'll come back through and listen to this the second time, and maybe not so much.
All right.
Yeah, that's okay.
I guess that'll be the benefit of being able to record these things, huh? Be able to watch them again.
Yeah, that's the nice thing too. Now it also matches up well with like those slides. So it's one thing to look at the slides in the abstract, but now, okay, you have a discussion where you can talk about, okay, you pick the left leg, which is what's in the slides. It's nice to have something that matches that for discussion. So either pre-course or really actually post-course, you can go back and look at the discussion point.
Yeah.
I'm
gonna make Katie describe all this stuff during the module 5 now that she's been on all these things. So.
Yeah.
Hey, Dave, you're referring to
Yes.
Gail's notes on module 5?
Yes.
Okay.
Yeah, so it should be right around slide 31. All right.
Hold on, I went back to you.
Tony, you have anything, or are you unable to unmute yourself? Sorry, Tony's from Wisconsin, so it might take half an hour to kind of get to there. So, Tony, you can formulate your question for next weekend or next week. If not, if there's any more questions on sacral torsions, certainly put them out there. We'll try and follow up on it, next week. It's always good to kind of come back with the functional questions too, and just, okay, what kind of people we're seeing, so it makes sense in your world, and tying it to running. I'm gonna go down the slides. A lot of the other slides coming up are, anatomically based, which are good for review. But I'll go through them and pick out a section, and we'll keep going on. If not, then maybe we'll do cases. Eric, anything you'd like to cover next week? It's okay if you don't have it on top of your head.
Yeah, I was trying to think of what the next logical step is from sacral torsions. The stride stuff, we're going to save a lot of that, because that's going to be a lot of our, module, whatever it is, 7 or 8.
Yeah.
I think it's module 8. as far as gait goes. So we're not going to get real into that during these things because we really want to be in the class for that stuff. But we could go over some of the fascial stuff at some point, and how, like some of this energy transfer, the kinetic chain stuff. Fred did we did a pretty good, actually I was with him. We did a pretty good podcast actually with with talking about the two of those things as far as how things interconnect the different fascial things. So you can actually find that. It's free. It's called Two Beers with Fred.
Two Beers with Fred, right?
Mm-hmm.
Yep. Yeah, we only did a couple of them, but that was a fun one because it had a lot of good functional stuff on how things are linked together. Because when we're thinking about the SI joint, we have to start to consider like the sacrotuberous ligament, sacrospinous ligament, the long and short posterior ligaments, and all that sort of stuff, and how the iliolumbar ligament kind of starts to affect motor recruitment, specifically of the psoas. So I think that might be something that we could cover, because there are ways to kind of use that even in treatment and diagnosis. So maybe we could think about doing that at some point. Maybe one or maybe a week, even a couple of weeks down the line before we really can break off of this and go to that. But that wouldn't be a bad thing.
That was really my next question, I guess, is because right now I'm not seeing patients, and so to try to like visualize this or come up with a imaginary patient of, okay, well, would they really be complaining to me about, and kind of when you talk about what tissue is actually the pain production site, and then I caught one of the videos of Gail palpating sacrotuberous ligament and then the posterior coccygeus, but it's like, those aren't really what a patient is saying. Well, I have pain here. Like, you go and find that, and okay, this is tender to palpation. And I guess kind of talking through, like, why would I go look to see if this particular structure is painful upon palpation, and what does that really tell me? Like with the sacrotuberous, like if that's, supposed to be restricting that nutation moment and it's not doing that, okay, now where do I go from here? What information has that given me? Does that make sense?
Yeah. So, specifically to the sacrotuberous ligament, it is gonna restrict nutation moment, right? But realistically, from a functional perspective, it's going to restrict nutation of the opposite sacral base. So if we have a right sacrotuberous issue, it's going to affect the left sacral base most substantially. I mean, don't get me wrong, it will affect both sides to some extent, but it'll be more substantial on the opposite side. But this is part of the equation here. When we're looking at how do these things interact functionally, coming up the hamstring, up the biceps femoris to the ischial tuberosity, the ischial tuberosity, that those fibers of that tendon continue on to the ILA as the sacrotuberous ligament. Those fibers connect there. Okay. They continue up through as the posterior sacroiliac ligaments, and they blend with the thoracolumbar fascia, and they tend to continue upward as the long thoracic paraspinals, the erector spinae. So when you have an issue at the sacrotuberous ligament, for instance, if it's slackened off, so if we have a right sacrotuberous issue, right, and it's slackened off, it would mean we have a left on right posterior sacral torsion, right? That left side of the sacral base will come back. This will come forward. That'll slacken off the sacrotuberous ligament. Now we have a chink, right? We don't have good load transfer from the hamstrings through to the pelvis. So we are going to, if we're bending forward to lift something, we're going to have a significantly increased load on the paraspinals, on those erector spinae, which will tend to produce an increased load on the lumbar discs, on the long lumbar ligaments, on the joint capsules of the facet joints. So being able to look at that and say, well, here's where we're running into some issues. The spot that you tend to be able to find that is you're going to have a weak hamstring. Because the connection there to the ischial tuberosity from the other end is going to be, we're going to have a laxity to it. So it's similar to the idea of having, I call it, Jim calls it, what's he call it? Not reciprocal, reflex inhibition. I call it, in that case, I call it a regional inhibition because it's coming from the girdle, right? So it'd be similar to having weakness in the shoulder because you have a bad sublux T2, right? It's not a true reflex inhibition because the problem's not in the shoulder itself. It's in the girdle that you're working off of. So I call that more of a regional inhibition, but you're going to have a weak hamstring. You know, you have a weak hamstring, you're going to have difficulties protecting your ACL, right? So, you know, you can chase these things all over the map. You know, you may even have difficulties with providing a stable ankle mortise because the biceps femoris attaches to the fibular head, right? And so if you can't fixate that fibular head, we talked about this during the peripheral course, right, Katie, where it pushes that up into that the bottom half of that tibial plateau. If you can't stabilize that, now all of a sudden your peroneals don't work real well. So you may have a wonky ankle as well, or at least an ankle that's more prone to that sort of thing.
Or you're not going to get that
comes
pull
in
on
and
the
says,
first
yeah, my issues. Correct. Yeah. So if you have somebody comes in and says, I have this bad ankle that I keep rolling and I don't know what the deal is, and I keep tearing the thing up, and you're looking at it and you're just saying like, well, okay, you know, where, you know, you're chasing these things up and you get up to that point where it's just like, well, you know, I really can't palpate any tension on this sacrotuberous ligament. It may be the last thing you get to, but if you find it, it's like, okay, well, we probably have a sacral torsion here. Well, why did we get that? You know, that may be playing a huge role in why the patient's having these kind of continued functional problems. On the other end, if you have increased tension, the most common problem there is you're going to say, I pulled my hamstring, because it's going to present very similar to a pulled hamstring, like a very high pulled hamstring. Going to be basically right on the sit bone, but you're just going to feel this big twangy rubber band structure, and it's going to be painful to touch. And that's essentially just the reverse of that. Now we've got this sacral or this ILA is backwards like this. This has been pulled forward, you know, and that's just kind of the secondary thing. That's usually due to a lumbar instability, because now the psoas is pulling that forward and tensioning this from the other end. So those things, yeah, I mean, occasionally you get the patient that comes into the clinic and just, you know, points at their butt and says, my pain is right here. You ask them, okay, does it go down your leg at all? No. Okay, does it bother you if I do this? And you resist the hamstring and they say no. Well, it's probably not a musculotendinous lesion then, right? So it's an inert structure. So what's the inert structure that attaches there? Well, it's that sacrotuberous ligament. So
I always feel like
occasionally you have.
I'm always surprised how many people come in and say they have problems with their piriformis and they point to their sacrotuberous. I feel like I get that frequently. Yeah.
Happens a lot. I actually treated a physician. I was at a marketing lunch, and the physician's just like, can you look at something for me real quick? I've got a piriformis syndrome. I'm just curious how to work on it. And I'm looking at him. I'm like, you don't have a piriformis problem. You know, did all the resisted tests, did all the stuff on the hip, and I'm like, you don't have a piriformis problem. It's a sacral issue. It's a ligament that's actually painful. And they, you know, kind of shook their head and they're like, I know piriformis syndrome when I see it and all that sort of stuff. And it's just like, well, here's why I don't think it is. You know, you rattle off about 10 reasons why it's not that. You say like, if I do this, I bet it goes away. You do this thing and it goes away. And then, you know, they get to, you know, ooh and all at you and send all their patients to you. But it does happen. It does happen from time to time. And it's just good to know, you know, what's the structure that's hurting.
So do you find when you do some muscle energy techniques or some sacral torsion techniques that they do have a pretty immediate change in the sacrotuberous tenderness?
Yeah, because now there's some give to it. If you get right on the bone, if you get right on the ischiotuberosity, it'll still be sore there because it's that you know, ligamentous or periosteal
reaction.
irritation. But if you get into the belly of the tendon, it's usually the tension that's causing the problem. Yeah, I mean, the muscle energy stuff is great because it corrects the positional fault. I mean, I may have to go in and do a manipulation of the SI joint just to get it free enough for the muscle energy technique to do something, just fine. Again, it's all in feel at that point. You know, what technique do you have to do? But if you're suspicious of that sacral torsion behind that subluxation, you've got to do the muscle energy technique to treat the underlying condition, or treat the first underlying condition, the secondary and underlying condition. The primary underlying condition would be whatever caused the sacral torsion, right? So you kind of have to do the stepwise process there. But, you know, it's it's doable. It's just a matter of, what's the most likely instigator. Once you get to that point, SI joints are never going to be an instigator. Like I said, unless you're dealing with a pregnant woman, a kid that's under the age of 12, or somebody that's got an active inflammatory process, it's not going to be a primary lesion. So you're treating the SI joint, you better be treating something else. Otherwise, you're only doing at most half the problem. Probably more likely only a third or less of the problem. So that's a warning. Make sure if you're looking at the SI joint, you're looking at something else as well. All right. What else?
I thought that was great, Eric. Thanks.
Sure.
I think that'll be interesting to think about all those fascial connections.
Yeah, it's interesting. And it's fun to think about, because you get these patients that come in with these random things that pop out of nowhere. And it's just like, well, you had to have had something had to have given out here. Why? Especially the people with those innocuous triggers. It's like, well, I just bent over to pick up a notebook off the floor, and I'm sitting in my chair and I bent over to pick something up and my whole back went out. I'm like, what? That's not a thing. That's not a trauma. So something had to have been underlying that. And, sometimes that failed load transfer, I guess you'd call it failed load transfer, but it's just that poor fixation. The chain had a problem in it and it just broke. All right, well, I got a patient coming in here in about 5 minutes, so I'm going to jump off with you guys, but I will see everybody next week.
Next week, do we want to talk case studies? Is that what we're planning on doing, maybe? To bring some cases to the table?
What to do is bring some cases that are kind of relevant to this conversation.
Okay.
Yeah, whatever you guys want to do, we can do. So
yeah,
if that's what you guys
if you don't
want
mind,
to do,
if I was voting, I would say I'd like to do some case studies to talk about this, to kind of drive home how we see this clinically.
Yeah, no problem.
I think I'd appreciate that too. Sounds good.
Great. All right, guys.
Thanks,
I'll see you next week.
All right. Take care.
Thank you very much.
Yep.